do is give yourself a hug. Yes, perfect. You know how to give yourself a hug. That's good. Yeah. Oh. Erase that. All right. So, elbows on top of each other like this. This is a non-committal hug, or what I like to call the corpse pose. So, and this doesn't get us the kind of leverage that we need for these procedures. The hug does. Go ahead and give yourself a hug. This gives me a nice solid contact here. It protects modesty too, and me from getting sued. This doesn't necessarily. Cross your arms like this, they're kind of wimpy. I think that she's like this. I go to grab stuff. Maybe I grabbed the wrong thing. Not necessarily. That's not really why we do this. Why we really want them to do this is because this gives me a nice solid contact. It allows you to go ahead and totally relax into my hand here. Yeah, right there. It allows the patient to relax, and it also gives me some leverage to move the patient around. If they're not crossing their arms like this, and they're like this, it's just less of all of those things. And I don't like it. It makes the patient feel very unstable in my arms. So a nice big hug like that. So now the first step is make sure that my hands are here. I'm going to ask the patient to give themselves a hug like this. I'm not going to be doing this. Yeah. It's like, obvious. But you all do it. And I don't know why. So please don't choke your patients, ever. If you have them like this, you don't need your arm up here. And I could probably get away with putting my arm here, but that's starting to creep up here. And it's not even that, some patients, they don't even mind. It's that I keep getting people to talk about it when you're in GPAs or like clinical synthesis or something like that. Like, why are the students holding up your neck? I don't know. I have no idea why. I stress not to, so please don't. Hold it down here. If anything, just to get them off my back. So here it is. Patient now can relax. Go ahead and totally relax in here. There we go. So with the patient relaxed, what position would you say the low back's in?
Flexion.
And when hers isn't that flex, can you flex your low back a little bit? Yeah. Oh, there we go. That's better. You have a hard time doing that. So flexion in the low back allows me to palpate the spinous processes. So let me put you back up here. Let me talk about a stop the madness moment. Let's stop the madness, please. No more palpating for the 12th rib and saying that T12 is there. First of all, that's not the 12th rib. Second of all, you can't just go straight across. You have to go at an angle, and the angle is determined by the angle of the patient's ribs. So that will always get you in the wrong spot. Because first of all, it's usually rib 10 or maybe 11, probably not 12. So if you got to find the lumbar spine and you really need to count, which eventually you won't have to, palpate the PSISs. Medially to that, the first SP you palpate is going to be L5 and then just count up. There's only 5 of them. It should be pretty easy. When you get really good at this is the fancy Hollywood way of doing it. Palpate the SPs in the thoracic spine. If you look at the skeleton, there's little knobby bits on the end. They're a little bit pointy. You get down the lumbar spine, they're chunky. Yeah, they're like this, but like thick. And you should be able to palpate that. So I don't even need to count. I know that right there is L1. Because it's the first chunk. Is it T12? I don't know. Maybe. Maybe your T12 is chunkier than your L1. I don't care. I really don't. If I do that, I'm also not going to say, well, you must have 6 lumbar vertebrae. Because I just messed up. Who cares? So you can count if you'd like. I would suggest counting up from L5. If you don't want to, you got to actually visualize the lumbar spine. And L1 should look like it's L1. I mention this because I see this in the final a lot. Like, we're doing this lumbar spine, you're up here. And I'm like, is that L1? They're like, yes, I counted. L1. Like, yeah, I'm pretty sure it's not L1. There's no ribs there. You could have a lumbar rib. I had somebody say it, I was like, come on. Let's just move on. That's not L1. So, what's that? So, yeah, it happens. And I don't want it to happen in this group because that made my head explode. So if you're not going to count, just make it look like you're at the top of the lumbar spine. It's pretty easy to do. And then if I ask you to do motion palpation of the lumbar spine in the final, do all 5 vertebrae. Some of you still, because you're nervous, might ask me, do you want me to do all 5? I'll say yes. And then some of you might do like this. Okay, I'm done. And then I'll say, did you do all 5? And then you're like, yes. Just know that that's what I'm going to expect. And I want that to be part of your flow anyway. If you're going to do motion palpation, just get used to doing all of them. It's really easy to do. So go ahead and give yourself out. So let me start with flexion and extension. Everybody learned this contact in thoracics? What do we call this? Can opener? I don't know why. Maybe because the old school can openers.
We didn't learn that.
You didn't learn it? What did you learn?
Nothing.
You didn't learn anything.
Just kidding.
No, I don't.
We never
recognize
did that.
I don't recognize that.
No.
Who'd you have? The grass?
Gormley?
Jake Gorman?
She did not, we did not do that.
Okay. All right. Well, we'll do this now.
Okay,
It's not
so,
hard.
no, I can,
We're
really?
doing this. We're making our hair like that. So the wrist is in neutral, so it's pretty strong. I don't want you doing something like this or your wrist like that. And you should be able to get these 2 contacts pretty level. This contact's going to go on one side of the SP, that contact's going to go on the other. So you're going to be straddling the SP like that. So you're really kind of pinching the spinolaminar junction or the entire SP. On your back, you have pretty tight low back muscles or really connective tissue. So I don't feel like I'm straddling the SP. I feel like here's the tip. I'm right there. Because the rest of it's connective tissue. So it's like that. Not like this. That's unrealistic. On some of you, you'll feel like SPs that you can really get alongside of. So, cross your arms again. Let's start with L1. Okay, I don't know what I'm doing. Tell me how to do extension.
Push in.
Push in. Did I do extension there? Say no. Why? She wasn't a part of it.
Oh, your arm.
Finish your words.
Because she has to do.
Because she didn't extend.
Yeah.
Yes. I bring this up because people think that, okay, here, remember, I have to, okay, can opener, can opener. Push B to A. Good? No.
Do you have to?
Not even. It's annoying. That's what it is. I mean, it might actually feel good if the patient, if the patient's tissue can handle that. But at the very, like the most it probably is annoying. You're not getting any motion at the joint, especially because if we have the patient kind of slump forward, they're in a flex position. So if we try to extend them in a flex position without it moving, we're not getting movement. Cross your arms. I'm going to use a lot less force, but I'm going to do this. Lift up here.
Yeah.
Push through.
So I was gonna say using his.
So you guys are convinced that's extension? I might not be getting all the way to end range, but you can tell it's extension because the patient's extended, right? But that's how I'm going to grade you in the final. So you got to see that. Now, tell me what the difference is between this and this.
Range of motion.
Yeah, one motion, but I'm probably moving all the way through the joint in the second one. The first one seemed a little weak. So when we're doing motion palpation, we gotta get the motion. We have to push all the way through till the end range, and then wiggle in the direction we're supposed to be wiggling, which an extension is this way. Flexion's going to be like that. Rotation's going to be wiggling that way, pushing on the SP. So that's all the joint play is. You go to that point, and you wiggle there. And that's essentially evaluating what it feels like to be at end range. And then we would, in extension, we only have a unilateral motion, but if it were rotation, we'd test the other side, and we compare those two. And if one side feels like it's not wiggling as much as the other, or the end range feels different, we call that a restriction. Does everybody understand that? Super easy. There's nothing, we don't have to get any more complex than that. Could I call the end range? Feels like a rubber band stretching. Feels like you're hitting a brick wall. Feels like purple. I don't know. Like really, do you understand what I'm talking about right now? Probably not, unless you would describe it exactly the same. But some of you may not. We just have to palpate it, get through, and you'll feel the joint end, and then you'll feel a little bit of that soft tissue give, because we're talking about synovial joints. There's a little bit of soft tissue give. We're not going to have like that bony end feel that we might get with like the elbow extension or something like that. So you don't really have to even describe it going across your arms. So we go to L1, I straddle the SPs, I lift up and back as I'm pushing through. This happens at the same time. I don't want to see this. They're not two separate, because that was just awkward. It was weird. Nothing happened. She contracted her muscles, because it was weird. So both at the same time, push through, right at the end, a wiggle. What'd you feel at the end? Purple. Did it hurt?
No.
Okay, your muscles contracted though. I don't know why. That's why I asked if it hurt. Sometimes, it's tender. I mean, I could get a little knuckly with this contact if I'm not careful. I try not to. So then I do that all 5 vertebrae, all the way down. Each time, patient extends over my contact. What do you think I'm going to do with flexion? Let's try to figure this out. Describe what I would do with the patient and to get their lumbar spine to flex segmentally. Pull their elbows down. Like that. Yeah. So, patient's going to be, keep yourself back up. I'm going to be pushing down and in as I grab those SPs and push them up. Like that. Without that, it looks like this. Let's say I go, okay, here. What am I doing? Who knows? I felt like maybe because you're already extended a bit, maybe I was extending you when I did that. But really, I'm just giving you a skin wedgie. So go ahead and just relax a little bit. Yeah, start there. Flex position. I grab the SP like that. I'm not really even doing that much with my contact. I squish, flex, push through at the end. Okay, I'll buy that. You're getting a little bit of flexion there. Not a lot. So far, everybody I've demonstrated on has a lack of flexion. So not a ton. But I feel like that is definitely a lot better than just flexing the patient and trying to push on a bone. Doing that all at once. Flexing, really kind of pushing in, and lifting the vertebrae up at the same time. Let's try those. Extension and flexion.